Hello, everyone, and welcome to another Autumn 2021 Michael M. Davis lecture/webinar. I am Keith Brown, the Administrative Director for the Center for Health Administration Studies, also known as CHAS, and I'm glad you all could join us today. Thank you for joining us online, and we hope to continue seeing you all here online or hopefully in person in 2022. In a moment, today's discussion moderator, CHAS co-director, GFAT faculty director, and Crown Family School professor Colleen Grogan will offer brief opening remarks and an introduction of today's presenter, Jonathan Oberlander, the chair of the Department of Social Medicine and also a professor in the same department at the University of North Carolina at Chapel Hill's School of Medicine. If you have any questions, please type questions into the Zoom Q&A pane for answering following the slide deck. The chat function will also be opened towards the end of the presentation to allow for questions to be discussed and flesh out further. We will do our best to answer all of those questions and foster the discussion between Professor Oberlander and Professor Grogan. A recording of this webinar will be featured on the CHAS website, chas.uchicago.edu, as well as on our YouTube channel, which can be easily found by searching for the Center for Health Administration Studies. And now Colleen Grogan will introduce today's presenter.
Thanks, Keith. Hello, everybody. Thanks so much for joining us. It's really my great pleasure to introduce John Oberlander. I've known John for a long time, and it's just always such a pleasure to hear him talk. I learn something new, something really insightful every time I listen to him. John and I crossed paths at Yale University in the 90s. So we go back quite a ways. But John wrote a book that I just want to still give a shout out to, because it's still, when people ask me about the Medicare program and anything about the politics of Medicare, I still tell them you need to read John Oberlander's book, and the title is The Political Life of Medicare. It was published in 2003, but it really gives it lays out the contours of the politics of Medicare as it developed from when it was enacted in '65 up to the early 2000s. And then since that time, in the last couple decades, John has continued to write quite prolifically on the Medicare program, Medicare politics, the passage of Part D. And so he's a wealth of knowledge about this really, really important program in the US, just essentially our, what people like to say, our one social insurance program in the US. And so John's the expert on that. But in addition to Medicare, he also just really knows about healthcare politics in America. And you can see from the title of the talk, he's going to tell us sort of hot off the press what's going on with the Biden administration. So I'm super excited to hear about that. His opinions about what's possible, what could come, what reform ideas. Again, John has also written about Medicaid, about prescription drugs, many other topics. He's also, aside from his really important job as chair of the department, he is also the editor of the Journal of Health Politics, Policy, and Law. And so really putting out some incredible issues. We were just talking about that before we went live. Lots of special issues that allow you to really grasp what's going on in a particular area. So I highly recommend looking at the acronym is JHPL, but the Journal of Health Politics, Policy, and Law for these recent special issues, but more to come as well. So with that, John, welcome. I'll let you take over.
Thank you, Colleen, for the great introduction and for all the plugs and for dating both of us, I think, back to the 1990s. And it is true. And it's great to be with you all. And I'm sorry that we can't do this in person, and sorry not to have the chance to see Colleen and Harold and others in person. And by the way, Colleen was one of the preceding editors at the Journal of Health Politics, Policy, and Law, and helped build the journal up to where it is. And really has been a pleasure for me to try and build on the work that Colleen and Eric Potashnik and others have done with the journal. So what I thought I would do today is sort of, well, I just came from teaching class. I'm sure some of you have just come out of class. So I thought I'd do what I generally do when I teach class, which is I'm just gonna sort of think aloud, which is dangerous and not really recommended. Do not try this at home, but I'm gonna do it and talk about the Biden administration and where we are in healthcare reform politics right now in 2021 in the United States. And there's so much going on. Obviously, there's been so much going on with COVID the last year and a half, plus that in a way, I think it's kind of hard to figure out where are we right now. And hopefully you can help me figure out where we are in health reform politics. So what I'm going to do is talk about the Biden administration, but I want to talk about it in context and spend a good amount of time thinking about how we make sense of what happened to the Affordable Care Act during the Trump administration, and then transition to talking to what's going on right now. So let's see. All right. So if we think back to the enactment of the Affordable Care Act a decade plus ago in March 2010, it represented a transformation of American health policy. And there's no question, if you look at the evidence on what's happened in the last decade, that there is lots to say in terms of the successes of the Affordable Care Act. It has done a lot of things right. It's done a lot of things well, and it has made lives better for a lot of Americans. But beyond policy, when it was enacted in 2010, I think it was transformational in representing hope in terms of its politics, because American health policy really, since the enactment of Medicare and Medicaid in 1965, American health policy had been sort of stuck in this purgatory where we were perennially declaring that we were in crisis, perennially proposing solutions to address the crisis, and perennially not adopting any of them, or only doing something incrementally, and then rediscovering that we were in crisis. And so you had lots of people like me who were writing depressing, dark, dire articles about how daunting the politics of health reform were, how strong the status quo was, how, despite the fact that we had a wasteful, inefficient, irrational, expensive, non-system for delivering health insurance in this country, that it was seemingly impossible to move forward in any kind of meaningful way. And yet the enactment of the Affordable Care Act in 2010 broke through that darkness, broke through that despair, even for me, and showed that you could have progress in healthcare reform in the United States, that you could move the status quo in important ways. And when the Affordable Care was enacted, I think the architects had reason to be optimistic about its trajectory. Let's remember that the debate over Obamacare was from the beginning a contentious debate, an ideological debate, a partisan debate. And it was a debate that the Affordable Care Act barely survived in Congress, but really only one vote in the Senate. And yet, if you looked at the experience of the Medicare program, in particular, you had reason to be hopeful that the politics of the Affordable Care Act would change, because the politics of Medicare that Colleen was alluding to earlier were themselves very contentious in the 1950s and early 1960s. And there was an ideological debate, and there was a largely partisan debate. And people have forgotten how difficult it was to pass Medicare. It was about 13 years from the time Medicare was proposed in Congress to the time it was passed. But after Medicare was passed, a lot of that controversy receded. And there was never a question over Medicare's existence. There was a bipartisan agreement that Medicare was going to continue as a program, disagreement on what the exact shape of Medicare should be, but agreement on the idea. And Medicare really became institutionalized. It became entrenched in American politics, and it became entrenched in American healthcare. And you can see here the quote from Wilbur Cohen, who is one of the architects of the Medicare strategy and the Medicare program, looking back at the 10-year anniversary and saying, Medicare has broken the back of the ideological opposition to the public role in health insurance. And that's what it looked like in 1975. A decade plus after the Affordable Care Act was enacted, sitting here in 2021, it doesn't really look like that. And the Affordable Care Act has had a very different political journey, a very different political trajectory than Medicare did in its first decade. And really the first decade of the Affordable Care Act has been defined by conflict and largely by partisan conflict. And that partisan conflict has persisted much longer than I think a lot of people, including me, thought it would. And the political scientists like I am, we teach our students that when you get a program and it's a large program and it delivers lots of benefits, it's going to develop constituencies. And over time, it's going to become popular. And as people experience those benefits, it's going to have a constituency of all those beneficiaries, and it will develop a sort of political cloak around it that will be protective. And that is more or less what happened in the case of Medicare. That's not what has happened in the first decade, at least not easily in the case of the Affordable Care Act. We have had this partisan struggle now. And the question that I want to ask, having been through a decade plus of this, and now with the onset of the Biden administration, is okay, after a decade of partisan struggle over Obamacare and with the election of a new administration, where are we? Where are we in American healthcare politics? Where are we in the politics of the Affordable Care? So let me tell you how I think about this, which is the way that I like to conceive of this is that there are four related but distinct fronts in the partisan wars over Obamacare. One is in Congress. One has to do with administrative actions taken by the president, by the executive. The third is at the state level, and the fourth is in the courts. And I want to just go through very briefly and talk about what has happened in those fronts, and particularly what happened in those fronts in the Obamacare struggle during the Trump administration. So let's begin with Congress. And of course, during the first 6 years of the life of the Affordable Care Act, there was no chance of congressional repeal of the law as long as its namesake was still in the White House and was going to veto, even if legislation made it that far, Barack Obama would have vetoed it. From the beginning, Republicans put a priority on repealing and replacing Obamacare, and certainly Donald Trump, when he campaigned for the presidency in 2016, this was one of his signature issues, one of his promises. And here we get into the realm of amateur psychoanalysis, but let's go ahead. It's a lunch Zoom talk, so let's go ahead and do it. But probably the fact that this law had Obama's name in it, and so it was literally the embodiment of Barack Obama as a program, probably didn't win it any more favors with President Trump. So he set out to repeal the law, had a Republican majority, of course, elected in the Senate, Republican majority in the House. And the night that Donald Trump was elected, a lot of people believed that that was it for the Affordable Care Act, that there was good reason to think that if not the whole law, then much of the law was going to be overturned. Then, of course, the Trump administration and congressional Republicans got down to the business of actually trying to repeal the Affordable Care Act. And I'll give you a second to just take this in. By the way, these dramatic pauses for comedic timing do not work at all over Zoom. I've got 1.5 years of teaching of awkward silence to prove it, but I'm going to give the moments of silence anyway. So Republicans discovered that repealing the law was not so easy. And I am a social scientist, so I'm supposed to be able to observe patterns and pick up on them. And I'm going to observe that Senator Mitch McConnell, Majority Leader of the Senate in 2017, was disappointed. And here you see him after the Republican attempt to repeal and replace Obamacare came up short and failed in the Senate. And this is just, 16 months or so into the Trump administration. And what Republicans have been promising for the last 7 years was already gone. The effort at this front, so this front of congressional Repeal failed. So it ended in failure even when Republicans had everything lined up for them. It did have some strange side effects. One of the side effects that it had was the effort to repeal Obamacare actually made the program more popular. It's never been, as Colleen can tell you and others who study public opinion, it's never been an incredibly popular law. This is not Social Security. This is not Medicare. And the American public has been very divided since the beginning. And you can see these divisions. And what's amazing is, going across years and all these things that have happened, all these different things that have happened in the Affordable Care Act, you can see that public opinion over the law remains divided and more unfavorable than favorable until you get to here, to 2017. And what happens in 2017? Did the law perform any better? Did any new provisions come online? Did it somehow get super more efficient? And the answer to that is no, no, and no. What happened in 2017 is that it was under threat. Republicans tried to repeal it. And when they tried to repeal it, they actually coalesced support for it. One of the problems that the Affordable Care Act has had, in my view, politically, is that it is not one program. It's a series of policies and regulations and subsidies, and it treats different groups of Americans in different ways at different times. And so I don't believe it has the coherent programmatic identity of Medicare or of Social Security. The relationship between the program, who is eligible for the program, and its benefits is far more confusing and complicated than those two programs. Not to say those programs aren't complicated, because they are, but people have a sort of basic idea of who they're for and what the benefits are. The Affordable Care Act is too diffuse. And as a result, I think it's been harder to mobilize a political constituency for it. And that's part of the reason that you saw those public opinion numbers lagging. But what we learned really in 2017, when there was an effort to repeal it, was there was a latent constituency for the law. Lots of things that the law does that are popular. And when those things became under threat, all of a sudden people's understandings of the benefits of Obamacare clarified. And so the repeal legislation that Republicans sponsored was actually the least popular bill, major bill in Congress of the last couple generations. And that is a dubious distinction. That's a hard one to achieve. And Democrats and Republicans both have clunkers up on that list. So the repeal effort was very unpopular, but it actually succeeded in making Obamacare more popular. And that's one of the odd legacies of failed legislative repeal. The other thing we learned was this. For years, we knew that the status quo in American healthcare is, as I said before, difficult to dislodge, that there's a lot of inertia in it, that we have all kinds of stakeholders, and they have a stake, literally a financial stake in current arrangements. What happened and what has happened in a relatively short time is that the Affordable Care Act has become part of that status quo in American healthcare. And so in 2017, when Republicans proposed disrupting the status quo, much of the healthcare industry, including, as you can see here, the Hospital Association said, no, wait a minute, we get it, you're not happy with the Affordable Care Act, but we don't want you to do repeal and replace. We don't want you to make deep changes to Medicaid. So the Affordable Care Act has gained inertia. It has gained that inertia that for so long kept reform from happening. Now that it actually happened, the Affordable Care Act is part of that system, or non-system, if you prefer, that's difficult to move. There are lots of reasons why Republicans came up short in their effort at congressional repeal during the Trump administration. But the biggest one is, in my view, they just didn't have enough seats in the Senate. Remember, the Affordable Care Act was passed at a time when Democrats had a supermajority of 60. Republicans had a very slim majority of 52 to 48 in the Senate. And the repeal bill actually did pass the House. It did make it through the House. And they just had one too many senators give a thumbs down. And if they had had 54 seats, 55 seats, 56 seats, I think we'd be doing a different talk right now, because I think some version of repeal and replace likely would have passed. And the United States Senate's difficult to govern always, but if you've got big ambitions and narrow majorities, that's a difficult combination to make work. The other thing that I'll note is that in the Senate, for maybe the first time in the first 7 years of the political life of the Affordable Care Act, we had that deep partisanship erode just slightly. So instead of all 52 Republican senators voting for repeal, you had 49 out of 52 and 3 that joined their Democratic colleagues. And that was significant, because even without that even small break in ranks, you would have gotten a different result. Now, whole-scale repeal, large-scale repeal of the Affordable Care Act failed. There has been some what I would call selective or targeted repeal, where particular provisions of the Affordable Care Act have been overturned by Congress. And this includes things like the Independent Payment Advisory Board, which was set up to work in Medicare and was supposed to help control costs in Medicare via an expert board. That is no longer with us. The Cadillac tax, which is so-called Cadillac tax, which is a tax on high cost private health plans, which was just about every health economist's favorite part of the Affordable Care Act, but unfortunately hated by just about everybody else who is not a health economist in the United States, and politically wasn't a great sell, since it was a 40% marginal tax on people's health insurance. That is no longer with us. And some of these things, including those two, were actually repealed with bipartisan majorities. The one significant part of the Affordable Care Act that the Republicans were able to overturn and effective, I think, in 2019, was the individual mandate, the penalty for people not buying health insurance. And that, of course, was zeroed out. And when the Affordable Care Act was enacted, that was regarded by most analysts as a central part of the Affordable Care Act. And if you didn't have that, healthy people wouldn't sign up for coverage, and insurance pools would become unstable, and enrollment in the Affordable Care Act's health insurance marketplaces, where the uninsured go and buy coverage, would plummet. And that all sounded like a good story, except largely it hasn't happened. And enrollment, as I'll show you a little bit later, has maybe gone down a bit because of the loss of the Affordable Care Act, and maybe it will, because of the loss of the individual mandate penalty, maybe it will get a bigger effect as time goes on, but it really only has been a modest effect so far. All right, so that's the legislative front, and the legislative front ended in the Trump administration largely with failure and largely not with a lot of achievement. And by the way, the three things that you see on this slide were three very controversial parts of the Affordable Care Act, and three parts that attracted a lot of public debate. You know, if I have a tree and I take out, I pare down three branches that are weak, the tree doesn't weaken. Actually, the tree gets stronger. So it's unclear that this was a political blow to the Affordable Care Act. Actually, you could argue that losing these three things, regardless of what they may be in terms of a blow, depending on your perspective, and policy-wise, politically, actually, this may have helped the Affordable Care Act by getting rid of some of the policies that were the most visibly unpopular. All right, what about administrative actions? Well, when congressional repeal failed to deliver, the Trump administration then turned to executive actions and took a number of steps that'll be familiar to you all. And essentially, these were designed to produce a self-fulfilling prophecy. And the self-fulfilling prophecy was particularly aimed at the health insurance marketplaces, formerly known as exchanges, the purchasing pools where people can go to buy coverage on healthcare.gov, or if your state operates one, through the state website. And they were hoping to destabilize the health insurance marketplaces and really setting them up to fail. And you can see they did a lot of things that made it harder for people to sign up for coverage, harder to get the word out, set up this parallel market of short-term health plans that were less regulated than Affordable Care Act plans, in the hope that people would go and join those. Also Medicaid work waivers as well. And finally, the cost sharing payments. So people who are eligible for subsidies in the Affordable Care Act, as you know, are eligible to get help paying for their premiums if their income is low enough, and also to get help offsetting deductibles and other kinds of cost sharing that they might have to pay. And there's a legal battle over this, which we may talk about later when we get to the legal front. But long story short, the Trump administration decided to simply stop reimbursing insurers for the subsidies that they had to give low-income people for these out-of-pocket cost subsidies. And when they did that, there were a lot of people, not just in the Trump administration, but outside, that thought that might unravel the health insurance marketplaces under the ACA. And you can see what President Trump thought, and you can see what Steve Bannon thought here, that they were going to blow it up, that this was the end of Obamacare, and a bit of hyperbole there, but really what he's talking about there is the end of the marketplaces, that they're just going to unravel. And that was not an unreasonable view to have, in the sense that insurers could have just packed up their suitcases and left and said, we can't deal with this instability anymore. We're not going to have the mandate penalty. We're not going to get reimbursed for cost sharing reductions. Let's just leave. And then the marketplaces implode. And so that was a hope by the Trump administration, a fear by allies and advocates of the Affordable Care Act. It didn't work out that way. And this is showing you the enrollment over time and people, the plans they're selecting in the ACA marketplaces. And you can see that enrollment has gone down a bit. So there was a drop during the Trump administration, and that probably has something to do with the impact of some of those policies, particularly the ones cutting back on advertising and cutting back on efforts to try and get people signed up for the federal part of this, because you can see the federal part is in the dark green, and you can see that's where the decline is. The lighter shade green, I'm not very good with colors, so I don't know what to call these. The lighter pale shade of green here of the state base, that remained pretty steady. And that's because states were trying to make this work. The federal government under the Trump administration was trying to make this fail. And there is some modest decrease here in enrollment, but by and large, the marketplaces have been arguably much more stable than people thought they would turn out to be. And that has to do with all kinds of techie reasons, including the response of the insurers, who found a workaround for this, working with states, something called silver loading. But the end result of it is that the marketplaces actually proved to be not exclusively, but relatively immune from attempts administratively to roll them back. And so that front in the Obamacare wars also ends at the end of the Trump administration, largely in disappointment. Now, coming out of this, we begin to get some signs as far back as 2018 that the politics of the ACA are shifting a little bit. The Democrats, of course, win big in the 2018 congressional elections, and that win is credited in part to the fact that Republicans tried to repeal the ACA. And Democrats ran lots of ads in the 2018 election cycle saying, look, your Republican representative was trying to roll back protections for pre-existing conditions, which is extremely popular. And the Democrats hammered that message home and home over and over again. And you can see Martha McSally in Arizona complaining about it and blaming her fate on it. And so you get a sort of shift. This is the first election, really, 2018, where Democrats ran on the Affordable Care Act and not away from the Affordable Care Act. It had been so controversial and its popularity so underwhelming that Democrats had not made it the centerpiece of a campaign until 2018. And then they made Republicans' efforts to overturn it a centerpiece. More evidence of the shift in health politics comes in 2020 in the election that we just had. And you can see Donald Trump here tweeting and Mitch McConnell, and they're basically saying the same thing. And what this is showing is that the politics of the Affordable Care Act had shifted to the point where Republicans believed coming out of 2018 that they had to say that they were in favor of protecting pre-existing conditions. Never mind whether, for the moment, whether their actual policies would have done that, they believed they had to say it because that part of the Affordable Care Act has become so entrenched and so institutionalized and just kind of taken for granted now that, again, the politics of the ACA had shifted. Further evidence that the politics of the ACA had shifted. This is not a misprint. It's not a slide where I just forgot to put like the bullet points on, although frankly, that could well happen later on if you give me enough time. But this was the repeal and replace plan for Republicans in the 2020 election. It was blank. There was no plan. Having been burned in 2017 and seeing the political fallout in 2018, Republicans, including Donald Trump, really didn't run on repealing Obamacare as a centerpiece of their election strategy in 2020. They really moved away from it, really moved away from Obamacare as a central issue. And again, that tells you something about the politics. All right, moving to an area where Colleen is expert, and that is state resistance. So the front of state resistance is a more complicated story, and there are different components of the Affordable Care Act where states have a say. One of them was setting up those health insurance marketplaces, and at the end of the day, most states decided not to set up a marketplace, and my state here in North Carolina defaulted to the federal government and healthcare.gov. That did have some impacts that we can talk about later, but the one I do want to highlight for now in terms of state resistance to Obamacare is Medicaid expansion. And when the Affordable Care Act was enacted, the presumption was all 50 states were going to expand eligibility under the ACA. And part of the reason there was that presumption is they had all done it before. All 50 states have hospital associations that want Medicaid expanded, that are worried about uncompensated care and that would like their patients paid for. And the Affordable Care Act said that if they didn't expand Medicaid under the ACA, they were going to lose all their federal Medicaid money, which no state could afford to do. But the Supreme Court made a ruling in 2012. They effectively ruled that Medicaid expansion was optional for the states. So they wouldn't lose all their Medicaid money if they decided not to expand their existing Medicaid money. And again, at that time, the sentiment was, well, states, it's in their financial interest, it's in their economic interest, their moral interest, their political interest, they're all going to do it. And a lot of states have done it. A lot of states have done it. 100% of states with Democratic governors and Democratic majority legislatures have expanded Medicaid. But a number of states that are Republican-led have expanded Medicaid. Arizona under Governor Brewer, Ohio under Governor Kasich, New Jersey, Governor Christie, and so forth. So there have been a number of Republican-led states that have expanded Medicaid. But we still have a dozen states, and I'm sitting in one right now, that have not expanded eligibility for Medicaid under the Affordable Care Act. And that has had an unexpected effect. It has essentially blown a hole in the Affordable Care Act in those states for low-income persons. Those states have a very high rate, a very high uninsured rate, I should say, for low-income persons because they have no viable options to get coverage if their state has not expanded Medicaid. And so this is an area where resistance really has had an effect. And the effect that it's had is an effect of decreasing enrollment, decreasing insurance enrollment. And based on the evidence that we have that's come out, it's had a mortality effect. It appears that Medicaid expansion under the Affordable Care Act saves lives. So when you don't expand Medicaid eligibility under the Affordable Care Act, the reverse is true. You lose lives. Also, of course, you don't have to be a social scientist to note there's a geographic pattern here, and the states are really concentrated in the South. And I think it's 8 of the 12 states that have not expanded eligibility under the Affordable Care Act are southern states, states of the former Confederacy. And it raises questions, I think, about the role of race and the role of racism and questions of deservingness and who people believe are getting these benefits or are going to get these benefits and how that shapes health politics. And Colleen wrote a wonderful paper about this. And so that legacy there of state resistance has mattered to the Affordable Care Act. And even though the number of states has increased over time, and the states where Medicaid expansion goes on the ballot tends to pass, if you get it to the ballot, if you get it to a ballot initiative or ballot measure, it tends to pass. Even in really conservative states, Medicaid expansion is popular. But a lot of these remaining states don't have that mechanism to put it on the ballot. And so here we are, 11 years plus, still with a dozen states that haven't expanded. All right, that brings us to the final front, and the final front is the legal front. And the legal front has been maybe the most surprising front. When the Affordable Care Act was enacted, there was a sense there was going to be litigation because there were state Republican attorneys general who were literally bringing suits the next day against the Affordable Care Act. But the consensus in the legal community was that these suits weren't going to go anywhere. It turned out that consensus was wrong, and the Affordable Care Act has had one lawsuit after another lawsuit, one case after another case, reaching the Supreme Court, and it's had some near misses, and of course survived in 2012 by John Roberts, one vote. It tells you something about the contingency of life, that the heroes of the Affordable Care Act in the last decade include John Roberts, Arlen Specter, and John McCain. If you had gone to Las Vegas in 2009, I'm not sure you would have put your chips down on those three, but that's the way it's turned out. So, we've had one case after another, and the last case was decided this past summer, and this, of course, involved the states. And so, as you can see, we had the states separating out into different sides on this, the red states looking to have the ACA overturned, and the blue states trying to protect the ACA. And the great thing about this case is it was simulcast. You could listen to oral arguments, and it was during the hour that I teach. So I just put it on for my medical students, and we listened to it for a while. And one of my medical students raised their hand and said, I don't get it. It doesn't make any sense to me. And I said to her, you've got it perfectly, because the case made no sense whatsoever. The case wasn't about the law. It was a sort of a ludicrous legal argument that rested on the theoretical damage done by a penalty, the individual mandate penalty, that no longer existed and didn't apply to anybody. So it was legally, it was, of the cases, probably the most absurd case, and yet it made it all the way to the Supreme Court. And the fact that it made it all the way to the Supreme Court tells you, I think, what you need to understand about the legal front. And that is, the legal front was simply politics by other means. The courts were converted into another institutional front, another partisan institutional front over Obamacare. And this had some advantages if you're a Republican and you're worried in Congress about voting for repeal. If a judge or justices kill it in the Supreme Court, it gives you at least a possibility of a little bit of political protection and distance. I'm not sure how well that would have worked out, but you can say, look, it's unconstitutional. They did it. We didn't do it. So it had some advantages. And the other advantage is, since Republicans couldn't make this work in Congress, well, maybe the courts can do it for us. But of course, at the end of the day, the courts did not do it, and the Supreme Court again upheld the Supreme Court. And this might be the last existential threat legally to the Affordable Care Act. I say might be because we've said that before, and then like a year later, another case comes. And there are cases on the horizon right now, challenges the Affordable Care Act coming via Texas again, but they're not existential challenges to the law. And so it is possible, it might be, that the legal front to the Affordable Care Act has ended as well. So, if you take all that together, what you would say is, well, during the Trump administration, those four fronts exhausted themselves, and Republicans had some modest success at the state level in terms of Medicaid expansion, resisting Medicaid expansion, but otherwise, the other fronts of struggle against Obamacare came up short. They failed. They were exhausted, even with Republicans in power, and a Republican president, Republican majority Congress, and a conservative majority in the court. None of these things that they wanted to happen came to pass. On the other hand, Democrats didn't get what they wanted. in the last decade. The political scientist Larry Brown, who's at Columbia, uses a term I like a lot, rationalizing politics. And what he means is that programs are enacted, and when programs are enacted, they have one stage of politics, and they go to a second stage after they've been enacted, and we make incremental adjustments and we try and rationalize them. And there's generally less controversy, more bipartisanship, more technical policy making. And that story really applies largely to Medicare. The Affordable Care Act had no rationalizing politics in the last decade. There are all these problems, many, many problems in the Affordable Care Act, some born of the design and the limits of the design, some born of the compromises the Obama administration and congressional Democrats made to get it passed, some problems born by resistance and partisanship. But it had lots of problems, and essentially none of those problems was fixed in the last decade. There was no rationalizing politics. The way to understand the politics of the Affordable Care Act between 2010 and 2020, it was a stalemate between Democrats and Republicans. Republicans didn't get what they want. They couldn't get rid of Obamacare or deal a large blow to it. And Democrats couldn't improve it. They couldn't build it. That optimism they had, thinking that maybe they can fill in some of its gaps and improve the law over time. For the first decade of the law, they weren't able to do any of that. We should remind ourselves that there are a lot of problems left over. Now, I want to be clear here. I do, as I said before, believe that the Affordable Care Act has made really important strides in American health policy and represents fairly remarkable progress. But we've got a lot of problems left in US health policy. There's only one rich democracy in the world where I could say I've got great news. 29 million, only 29 million people were uninsured in 2019. And that's the United States. In any other country, rich democracy, that number would be catastrophically high. So we're not close to universal health coverage, even a decade after the law. And if you just look at the side of uninsured children and think about the direction we've been going, we've added in the last 4 years, something like 800,000 more children are now uninsured in the United States in the last 4 years. And again, just a reminder, and if somebody asked me and they said, oh, show one slide to indicate that we've got a lot of work to do in US health policy, I'd probably just give them the slide and say, look where we are with uninsured children. We talk all the time about the uninsured. What about the underinsured? Folks who have coverage, but the coverage is not really all that protective, and they're subject to very high costs. The Commonwealth Fund has been doing great work on this, and they've got their own measure that you can see in the small print here about what underinsured means. Pay attention to the this bottom line, in particular about employer-sponsored coverage, because that's what most Americans under age 65 still have. Employer-sponsored coverage, what, 150, 160 million people. And over the last decade, that coverage has continued to thin out. The deductibles have continued to rise, and people's insurance has continued to get worse. And one way of thinking about the Affordable Care Act is it did a really good job at reducing the uninsured population, but it has not done a really good job at addressing the underinsured population, particularly those with employer-sponsored insurance, whose coverage continues to be, well, more and more under. And then COVID, I don't even know where to start with COVID. COVID has exposed so many pathologies about US healthcare, so many inequities, and they're familiar to you all. But I did want to just highlight the story from the fall of 2020, a year ago, in the Wall Street Journal. And they did a story about how there were hospital systems in Southern California who refused to accept or delayed accepting COVID patients because they were uninsured or because they had Medi-Cal, which is California's version of Medicaid. And look, countries with universal health coverage, like England, have struggled, like France, like Italy, they've struggled with COVID. So it's not as if having universal health insurance meant you were going to be great at COVID policy. But there's only one country that I know that in the middle of a pandemic was having hospitals refuse patients based on insurance status. And the point I want to make about this, and what's really distressing about this, is we're reading this in 2020. a decade after the Affordable Care Act, we still have these perverse incentives, these moral pathologies are still ingrained in US healthcare. They're still running through US healthcare, and the ACA was not able to get rid of all of them. And that again is a reminder of how much work we have to do. Speaking of how much work we have to do, okay, so that brings us finally to the Biden administration. What's going on with the Biden administration and healthcare? And clearly this is a work in progress, to say the least. I want to take you back to the campaign, and everybody treats campaign platforms seriously, and they should, because they're an indicator of what presidents will do, but they're not a perfect indicator. And if you look at the bottom, probably the two provisions that got the most attention, the most publicity during the campaign were establishing a new Medicare-like government program, a public option for the uninsured, and also the insured to buy into, and expanding Medicare eligibility and extending it down to age 60 from 65, where it is now. Neither one of those things is on the table in 2021, and neither is likely to be on the table in 2022. So for starters, the part of the Biden health plan that got the most attention, and in some ways was part of the most ambitious, that just sort of has been out even before we've gotten started. That's really not a central part of the conversation in Congress right now. Instead, what President Biden is working on has more to do with the first three bullet points you see here, and that is building on the ACA, trying to do that delayed and deferred repair work on the ACA, that rationalizing work of filling in the gaps. Some of this has happened through executive order. So one thing the Biden administration has done, like the Trump administration, is use a lot of executive actions, executive orders, and other administrative actions. That is a tempting strategy for presidents if you're having trouble getting things through Congress. And it's tempting. The flip side of it is it's impermanent, as you can see, because the Trump administration put forward all these executive actions, and the Biden administration is simply has reversed them. And some of these around Medicaid work waivers, public charge, rules around immigrants and their treatment in terms of public eligibility for benefits are really incredibly consequential. So the fact that it's not passed through Congress doesn't mean it's not consequential. Then there was ARPA, the American Rescue Plan Act, which passed last summer. And that, of course, had provisions in it to try and address the fact that the Affordable Care Act, in particular, has not been very affordable for middle-class Americans. Because of the compromises made in 2010, the subsidies were fairly limited. There were no subsidies available for people making north of 400% of the federal poverty level, or about $50,000. For an individual, and for lots of people under that, they were eligible for plans that had a really high deductibles, and the premiums were a good share of their income, and that's one of the reasons a lot of people weren't signing up for coverage. So among other provisions, the American Rescue Plan Act contained those subsidies. All right, so what about what's going on right now, finally, with the reconciliation bill? So the Democrats, as you know, as well as I do, and probably better than I do, the Democrats are trying to decide what to do. They've got a bunch of different priorities, but they're having difficulty deciding what to do. And these priorities include making the subsidies permanent that I just described, that make the Affordable Care Act plans, the private plans in the marketplace, making them more affordable, making those subsidies permanent. Doing something about that Medicaid gap. No state has yet taken the Biden administration up on the offer that was in the rescue plan law that was passed in the summer, where states would get more money if they expand Medicaid, although we are, I can tell you, talking about it here in North Carolina, and there's at least a possibility North Carolina is going to move, but no state has taken them up on that. And so maybe if the states can't do this, maybe you need a federal solution. So they're talking about a federal solution, an alternative to address that gap in Medicaid. Home and community-based services, which are incredibly important. We've got over 800,000 people and plus across the states waiting on wait lists that can't get these services. So funding there. Medicare has lots and lots of gaps in it, including vision, hearing, and dental, which you would think would be fairly important to the populations that Medicare serves, and finally empowering the federal government to negotiate drug prices in Medicare. Occasionally, people ask me, well, how can we afford to do all these things? And my answer to that is, well, really easily, actually. We already spend about $4 trillion on healthcare a year. So the idea that we can't afford to do the top 4 of these things at once is absurd. Of course, we can afford it if it's it's a question of priority, not do we literally have the money. To take just one example, the Medicare benefits that they're talking about, enhancing Medicare benefits, that would cost somewhere in the neighborhood, depending on how they do the plan, of $350 billion over a decade. Well, that sounds like a lot of money until you say, well, Medicare is already spending $800 billion a year plus now, in the context of a $4 trillion healthcare system. So of course we can afford to do these things. It's just a question of political priority. And this is going to sound familiar. Big ambitions, narrow majorities. Obviously really difficult to get what the Biden administration wants to get through, and needing every single Democratic senator, having no room for error, no room to lose even one, or it sinks the package. And by the way, one of the things that they've got to figure out, and is kind of a hard thing to figure out, is not just what to pass right now, but what can they get entrenched? What can they get passed that's going to produce benefits and be popular enough that it's not going to be overturned? And that's a non-trivial debate to have, because one of the ways you can try and make this work and square the circle and make this less expensive is to start programs later on. But if you start them later on, or if you end them, if you start them and sort of have an artificial end date, which is another Washington budget strategy, then you run a risk. And so they've got to weigh which of those to take. The intra-party divisions are serious. They are serious. But my guess is, and it's just a guess, and I'm a pretty lousy guesser, that eventually they'll overcome them and they'll pass some kind of reconciliation bill with some healthcare provisions. But the intra-party divisions, I think, in the longer run, are not the barrier to more healthcare reform. Because the question of more healthcare reform, my view is, as you can tell, where we are is not good enough. We've come a long way, but we've got so much further to go. And the question is, how do you get there? And when you start thinking about how you get there, you run into this. And this is Political Scientist, one of our favorite charts. It's showing you ideology. Up is conservative, down is liberal. Republicans more conservative than Democrats. Okay, that's kind of obvious, but we're good as a field at telling you obvious things. But look at the trend over time. Republicans in the House become a much more conservative party. Democrats become a somewhat more liberal party. And the result is we get this ideological chasm. I think that ideological chasm that you're seeing right there, which by the way, is the largest we can measure in the distance ideologically in the parties in Congress since the Civil War. And that was, the Civil War. That chasm explains why the Affordable Care Act has largely had such a difficult decade. I think it's mostly not about the Affordable Care Act itself. I think it's mostly about this polarization that's gone on in American politics. And it's not just about ideology. This is another chart that's showing the competitiveness of elections. When you see the big red lines, that means Republicans were dominating congressional and presidential elections like the 1860s. Think Abraham Lincoln. When you see the blue lines, that means Democrats were dominating. So this is Franklin Delano Roosevelt and the New Deal. This is Lyndon Johnson in the 1960s. You see these purplish little squares here near zero? That means we have had the longest sustained period of competitive elections that we can measure in American political history. And this is work that the political scientist Francis Lee has done. And the idea here is that one of the reasons that bipartisanship is so hard right now is not just because the parties are ideologically apart, but because when elections are this competitive, it creates a disincentive for them to cooperate. Instead, they just want the other party to fail because they think they have a good chance of winning the next election. And there might be something to that story as well. And you can see this hyper partisanship, this hyper polarization in other ways. And one of the ways you can see it is the disappearance of split ticket voting. So split ticket voting, where people in a congressional district would vote for one party for Congress and another for president, that used to be really actually very common, almost half of the time here in the latter part of the 20th century. Now look what has happened in the last 2 decades to split ticket voting. You get down in the 2020 election, and there are very few seats left that are mismatched seats, where they voted for a Democrat for a House, and in that district they voted for a Republican for president, or vice versa. It doesn't exist anymore. It's almost gone the way of the dinosaur. In the Senate, there are only 6 senators, I believe, right now out of 100 who represent, who are a party that's different than the party that their state voted for in the last presidential election. And in the last 2 Senate cycles, where we've had something like 69 senators up for election or re-election, there's only one of them who has been elected against the presidential preference of that state. So that again is more evidence of this partisan balkanization, this partisan polarization, this hyper partisanship that really makes it difficult to move forward in health policy. So wrapping up, are the Obamacare wars over? Well, I'm a political scientist and I'm pretty lousy at predictions, so I like to hedge. So I would say for now, yes, for now. And I think people have sort of lost sight of the significance of that court case last June and the other things that are happening with the Biden administration and the incremental reforms that were passed last summer. I think they're a sign that actually we've moved into a different stage of Obamacare politics, and that the existential fight over Obamacare that we had for a decade, I think that is over. And we're moving to a different stage, if you want, a rationalizing politics stage while Democrats are in office. Now, the more interesting question is, what will happen in 2025 if you get a Republican president with a Republican House and a Republican Senate? What happens to Obamacare there? And that's a hard thing to predict in a country that where democratic elections and democracy itself just barely survived in 2020. It would be foolish to predict what's going to happen in 2025, but I'm going to give you my guess. And my guess is that actually it's too late for Republicans to largely overturn Obamacare. And it's been too late for a while. It's just that Republican policymakers haven't leveled with their base. But too much of the program is too intertwined to roll the whole thing back. I think the political cost is probably too high to do a major repeal, meaning all of the Affordable Care Act goes, or most of the Affordable Care Act goes. However, I don't think that means that the Affordable Care Act is completely out of the woods. I think because the polarization is so strong and so really unprecedented, that the normal political rules of gravity that govern political programs and political entrenchment, maybe they don't hold quite the same way right now. So my prediction, which again, take it with a grain of salt, because it could be totally wrong, would be that a Republican president, Republican House and Senate might execute a war of attrition on Obamacare, not an existential war, but a war of attrition, try and undermine the program in different ways without trying to do a full rolling back, which cannot rule out, but I would consider unlikely. So I think for the moment, we are in a different stage in Obamacare politics. And the question is sort of, where do we go from here? As I said at the outset, the Affordable Care Act has had so much success and represents promise and hope, but there are so many limits to it. We have such a long way to go. And even if you don't support it, it's easy to understand why people support radical solutions. And I don't mean radical in a bad way. I just mean a departure from the status quo. Medicare for all and other things that just radically break from where we are, because after a decade of the Affordable Care Act, we've still got a lot of problems, and I'm hoping we find a way to address them. I'm going to stop right there.
Great. That was wonderful. I loved how you walked us through the past decade of the ACA and kind of broke it down by Congress, the executive, the states and the courts. That was really, really helpful. And I really liked your term, moral pathologies. That's such a problem with what the current system and how that was really brought out in COVID. I know Harold has a question, but I thought I would start us off. I guess I also really appreciate that you kind of had those four main policies that are currently being considered in the reconciliation bill. And of course, I agree with you that of course we can afford them relative to how much money we spend on healthcare. At the same time, just think about the name of the Affordable Care Act, right? Like it was supposed to do something about affordability, which it never did. It essentially expanded coverage, but never made the system more affordable. It never, people talked in the beginning about it's going to bend the cost curve. And there was a little bit of evidence in the very beginning that maybe that could happen. But then, the costs have just gone up. And on the cost side, the system arguably looks much, much worse, a decade in. Just thinking about the consolidations in the system and, the power of these large monopolies to set prices and surprise billing. You have private equity firms coming in and taking over and playing a large role in the whole surprise billing situation. So that also kind of seems to me that maybe the politics has shifted a bit in terms of the ways in which the system has changed. I've been thinking about that. And so I'd just be curious what you think about that. And so a little bit more, I guess, on the interest group side, how have maybe interest group interests changed or become more entrenched in certain ways since in the past decade that might make it harder or easier to make some changes going forward? I wonder what you think about that.
Yeah, I think so. Two things there. I think the cost story is a complex one, Colleen, because I think, if we look at projections of what we were going to spend in 2020 that were made in 2010, and we look at reality, we're way below what was projected. And that's a surprise and a credit partly to the Affordable Care Act and some of the cost containment mechanisms working better than expected. It probably has something to do with what the private sector is doing, but I don't think most Americans feel that who are insured. And that's because even though the premium growth is lower, the deductibles and copays and so forth are going up for a lot of people. So they feel like they're uninsured and then or underinsured. And of course, with surprise billing, which we did get, by the way, some bipartisan action on that recently. And the further you go from Obamacare, the more potential there seems to be for bipartisanship. The interest group question is an interesting one. I don't think any of us were talking about private equity a decade ago in healthcare, or at least I don't remember it. And that's a major new player, as you've written about it. And there's no question in not just in this front, but in Medicaid managed care and other areas that's shaping US health policy. I think, I'm not sure I have a good answer to that. I think that interest groups, by and large, the major interest groups in healthcare have sort of mostly, with some exceptions, coalesced around the ACA. And whether they supported the ACA or not, they've come to accept the ACA as part of the status quo. And so I think that explains why it's harder to dislodge the ACA, but that doesn't mean it's easier to move them on some of the other domains.
Mm-hmm, mm-hmm. Yeah. No, and I appreciate what you said about the cost. It's always, it's complicated. So I appreciate you pointing that out. There's lots of questions just came in as you were talking. So why don't we start with Harold's? Let's see, he says the GOP House repeal and repair bill was conspicuously poorly crafted, most dramatically in its increase of net annual healthcare premiums from $1,700 to $14.6 or $14,600 a year for a 64-year-old woman with an annual income of $26,500 a year. how does he pull that out of his pocket? How large of a role was poor legislative craftsmanship in the failure of the repeal and replace effort?
Yeah, hi, Harold. Yeah, so, Harold, I know exactly what you're talking about, and I often use that slide in my talks. I didn't today, but when pressed, I can bring it up. So I think poor legislative craftsmanship did play a role, Harold, but in a way, I think it was not the most important thing. I think the most important problem was Republican philosophical commitments and political commitments and ideological commitments were not compatible with producing a replace bill that was going to do a very good job. I don't think it's just that they, designed this poorly, which they did, but just that, in order to make this kind of work, you've got to do regulation and taxes and subsidies and redistribution. And if you're not willing to do that, then the health plan that you produce is going to de-insure a lot of people. And I think that's actually largely what happened. I take your point because on top of that, there are also just some strange and strangely poor things done in designing the bill. But I think it's actually a reflection of, the conundrum the Republican Party faced. And part of that conundrum is the Affordable Care Act contains a lot of what used to be Republican positions on healthcare, competitive markets and individual mandate, and these things that Mitt Romney, of course, supported in Massachusetts. And if you're running against those and you don't want to do those, then what is the position? And well, the position tends to be, okay, send things back to the states and deregulate. That's a position, but it's hard to create a coherent bill around that. And it's certainly hard to insure a lot of people.
Yeah, that's really true. A few people writing comments to thank you. Hopefully you're seeing those in the chat, John. Fantastic talk. But we have a question from Joe Fineglass. He asks, is there any hope of a Medicare expansion to age 55 or a buy-in per a federal exchange? Why isn't this more popular?
Oh, it's a sunny day here in North Carolina, so I'm full of hope, Joe. I think there is some hope over time. I'll just take a step back historically and point out that when Medicare was enacted in 1965, they never thought it would be for persons 65 and older 50 plus years later. That was not the goal. The goal of Medicare was to expand eligibility over time. So Medicare for all is a prominent slogan now, or Medicare for more, but it's an old idea. And actually, originally, they thought Medicare was going to expand to children next. And of course, that doesn't happen. And Medicare has been in many ways frozen, other than the important exceptions of adding the end-stage renal disease population and the population with permanent disabilities. I do think this idea is picking up steam. It's picking up steam partly because it's a compromise for Medicare for all folks who Medicare for all can't get that politically. Maybe we could get Medicare for more. It actually is incredibly popular. If you look at the Kaiser Family Foundation data on this, you'll see in their polls that this idea, exactly what you've described, polls really, really well, and actually is very popular among Republicans. Not just Democrats, but Republicans and independents. But it polls really, really badly among the insurance industry and really badly among the hospital association. And the insurers are worried, obviously, about the expansion of the government boundary, and the hospitals are worried about the purchasing power of the federal government. I think if you had a different kind of Democratic majority in Congress, then this would be something that would have a real chance. And Colleen asked that question about interest groups. One of the areas where there might be some modest movement is there are some large employers, after all, many of whom have stopped providing retiree health benefits, who have come around to the idea that, well, actually, would it be the worst thing in the world if Medicare stepped in and covered people 60 and over? Maybe actually that might be a good deal for us. So you might get some movement on the employer part of the interest groups there, but the moving the boundaries of federal health insurance in the United States is always ideologically contested. And then you've got some stakeholder groups that are absolutely dead set against this. So I think there's hope for it, just not in 2021.
Yeah. So here's another question. sorry, she first says health insurance and healthcare shouldn't be political, which we all would like to be the case, but I think your talk showed how deeply political it is. But then she asks, how do ERISA and small group changes, or how can they help in the shift of true coverage towards, I guess, more comprehensive coverage, maybe is another way to ask that.
It's a great question. And I just scanning this morning, I saw that Commonwealth has a new report out by Mark Hall and others on the small group market, and we probably don't talk about it enough. And look, the Affordable Care Act tried to move the ball down the field there. That's one of the things it tried to do. I think one of the questions that any health reform plan has to answer going forward is, what is the future for employer-sponsored insurance? It's been resilient. I mean, a lot of people predicted that employer-sponsored insurance would unravel under the Affordable Care Act. Has not happened, has remained really, really stable. And yet, if we scan out in a longer horizon, and we look at the small group market, over the last 2 decades, there is a real erosion in the percent of small firms providing coverage. So I think I don't have a good answer, unfortunately, to your good question, but I think that is something that any health reform plan has to decide what they want to tackle on a larger scale, which is, what is the future going to be of employer-based coverage, and particularly in the small group market?
Yeah, just on that question, because one of your kind of second main problems that still exist in the US, which I think is such an important point, is the problem of underinsurance. And I thought it was so important in your slide to show the extent to which this is an issue for employer-based coverage. So just was curious, do you think there's any possibilities to make movement on this problem of I mean, really, mainly their definition around underinsurance, as I read it quickly, but I've also seen the Commonwealth work in this area, is paying over 10% of your income on out-of-pocket costs means that you kind of fall into that category of being underinsured, and a good number of those people have employer-based coverage. So I don't know, I just wonder if you have any thoughts about that, if you think there's room to make changes there.
I think the politics are moving and the policy is behind it. I think in a way, the debate over Medicare prescription drugs is a underinsurance debate, except in the Medicare program, because of obviously the myriad gaps that exist in Part D Medicare prescription drug coverage. I think the politics of this are shifting. I think the surprise billing, which we talked about earlier, and it didn't get a lot of attention, that Congress did pass the surprise billing reform. I think that was in a way a sort of fig leaf to this issue. I might be wrong about this, but I think part of the energy behind Medicare for All in recent years is because of the growth of underinsurance. So I think rising underinsurance has the potential to really change American health politics and make some options more viable that weren't as viable previously. But the short term and in the medium term, the solutions really, if you're not able to create a public option and you're not able to do something bigger than that people with employer coverage can buy into, then the policy arsenal there to help people with employer-based coverage at the moment is pretty limited. So I think this is a case where the policy is far behind the politics. And so unfortunately, I'm not optimistic in the short term about that one.
Yeah. Hannah McDougall asks a really interesting question. She says, I appreciate your point about the lack of one cohesive message under the ACA, which made it harder to promote under the attack. Are there historical examples of complex health legislation creating a more cohesive message?
Great question. Well, Hannah, mostly our legacy is one of failures. We have lots of failures to point to. I think, in a way, it may be unfair to pin it on the complexity. Look, Medicare and Social Security are not easy. If you ever try and read, if any of your relatives is on Medicare, try and read through some of the coverage things, it's not so easy to understand. Social Security, not so easy. But at the end of the day, as I said before, there is a sort of simplicity about them, and it has something to do with their social insurance character, about who they cover and what they're there to do, that the Affordable Care Act doesn't have. And, lots of people faulted Barack Obama for his messaging around the Affordable Care Act, and in particular, Hannah, for the failure to message about how the law would help people with insurance, because morally, we might think the most important problem is we have this big uninsured population. But politically, most of the population has insurance. That's where it is. And there was a lot of criticism a decade ago, and probably for good measure, that they didn't do a good enough job explaining what's in the law to help people with insurance. But if we go back another decade, now we'll go back to when Colleen and I were at Yale, to the early 1990s. If we go back to the Clinton plan, Bill Clinton was another president who was renowned for his communication skills, and that just imploded. So I unfortunately, I don't have a great example. Colleen, if you've got a great example, feel free to offer it up right now.
Yeah, that's a good question. I was kind of thinking about that myself. Of course, I think there was galvanizing language that got Social Security and Medicare to pass. Like, I think the cohesive message worked for those two programs. Maybe the kind of Medicaid expansions in the 80s, there was a cohesive language, but it was so incremental. It's kind of, you don't get that massive cohesive language in incremental expansions quite so much, but I think it helped make it bipartisan. It's kind of interesting to think, do you only have big cohesive messaging when you're trying to do a big kind of big bang reform? I don't know.
And this is, if I can just add quickly, this is a problem with the reconciliation bill. I can't remember anymore. This is part of midlife, but I saw somebody say this on TV, and I agree totally. Nobody knows what's in the reconciliation bill. All we are arguing about is, should it be 1 trillion, 2 trillion, or 3.5 trillion? This is a serious messaging failure that the Biden administration really should be out there saying, this is not about $2 or $3 trillion. This is about child tax credits.
Right.
This is about helping families with persons who have disabilities, helping them stay at home. This is about helping ensure that Medicare beneficiaries get dental care. So that if you want another example, not of messaging success, but messaging failure, there you have it, Hannah.
Yeah. There's a couple more questions in the Q&A that I had missed. One from Mike Cutting and one from David Innes. I apologize to both of them. I think we only have time maybe for one more. David Innes kind of asked, I guess, sort of the question I asked, what has the ACA accomplished in cost control? And he put in some data on private insurance prices paid to hospitals, kind of evidence that it has increased. But I don't know if you want to respond to that at all, John.
Sure. David, you must be sitting next to Harold pulling out all those figures. It's something about University of Chicago. I don't think I give talks lots of Zoom places elsewhere. Only at the rigorous University of Chicago am I confronted with all these numbers. All right, so here's the deal. You could tell one story about the Affordable Care Act and cost control, and it goes something like this, that much of the major provisions to control costs in the Affordable Care Act have failed or proved disappointing. The Medicare Independent Payment Advisory Board, gone. The Cadillac tax, which was supposed to be the most powerful lever to control costs in private insurance, gone. ACOs and delivery reform, middling, not really great. So you can tell that story that in a lot of the cost control apparatus, the Affordable Care Act has failed. There's no question that we still have very high costs. But the flip side of the story is, if you look at the rate of growth in national health expenditures over time, it has moderated, and it has stayed moderate despite the fact that we added 20 million people. So that to insurance. So that is a success story, and the Affordable Care Act has done better, and we've done better as a country than I thought we would in 2010 at moderating the rate of growth in healthcare spending. So problem not solved, but no question that the Affordable Care Act's policies, including those in Medicare, really have slowed down the rate of growth in healthcare spending in the US. Doesn't mean it's solved, doesn't mean it's permanent, but it is a meaningful difference.
Yeah. Maybe one distinction is that the Affordable Care Act was able to moderate costs on the public insurance side. But costs have really increased quite dramatically, I think, on the private sector side.
And
And so
private
overall,
costs-
maybe, yeah.
They're going up, and but again, it's not. This is where we get to the underinsurance. Where they're going up is more on deductibles and copays. The premium growth also has been fairly moderate, but we're going off of a big base. But yeah, people just feel underinsured, and they feel underinsured because they're increasingly they are.
Yeah. All right. Well, I think we've reached the end of our time with you, which is unfortunate because people are still asking questions. But I really appreciate you taking the time, John. As always, it was really fun. I learned a lot, and just want to thank you for coming and sharing your knowledge with us.
Thanks so much for having me. I look forward to my next visit where the University of Chicago drops all kinds of random statistics right on my head. Can't wait.
Okay. Thanks so much.